We are live.
Ma'am, unmute. You're still mute.
Yeah. So we welcome everyone to this live webinar on the nuances of working with the digital microscope technologies, and we'll be talking basically about the anterior segment surgeries. And we'll first introduce the speakers, and I have my co-moderator, Dr. Rajesh Sinha, who is going to be moderating the session with me, and we have an eminent galaxy of speakers with us today to talk on this subject.
Well, thank you, Dr. Namrata, for initiating this wonderful webinar. Professor Namrata Sharma is the Dynamic Secretary of AIOS. She's also the Regional Secretary of Asia Pacific Academy of Ophthalmology. And she is also the Secretary of Eye Bank Association of India and Chairperson, Indian Society of Cornea and Cataract Refractive Surgeons. She has numerous publications, more than 380, 400 publications in various journals, 19 book chapters. She has authored 11 books and has been actively into academics throughout, has received numerous awards, both internationally and nationally. So it's really wonderful to have you in this webinar as the moderator.
It is my privilege, it is my pleasure to introduce Dr. Rajesh Sinha, who's the co-moderator, who's Professor of Ophthalmology in Cornea Lens and Refractive Surgery Services at RP Center. Having completed his MD Ophthalmology as well as DNB, he acquired FRCS degree and FAACL and has also done a fellowship at University of Washington. He has over 320 publications with 3 textbooks, 4 educational manuals to his name. He's the editor of Kerasite, past editor-in-chief of Delhi Journal of Ophthalmology, DOS Times, and lead guest editor for special issue of Journal of Ophthalmology. He has been a part of 3 multicentric FDA clinical trials and has presented many scientific papers and instruction courses both at national and international platforms, and received several awards, including the Achievement Award by the American Academy of Ophthalmology, Asia Pacific Academy of Ophthalmology, SAO Excellence Award by SARC Academy of Ophthalmology, International Ophthalmic Hero Award, Krishna Sohan Singh Trophy for the Best Clinical Talk in DOS, IRSI Gold Medal, Ecoin Gold Medal, and Bharat Jyoti Award. He is the treasurer of All India Ophthalmological Society, SARC Academy of Ophthalmology. He is the General Secretary of Indian Society of Cornea and Cataract Refractive Surgeons and treasurer of Eye Bank Association of India and past General Secretary of the Delhi Ophthalmological Society.
We have a galaxy of speakers, and the person who's going to be the opener in this series of talks is none other than Dr. S.P.S. Grewal, who is the founder and CEO of Grewal Eye Institute Private Limited, Chandigarh. He completed his MBBS and post-graduation in ophthalmology from Government Medical College, Patiala. Dr. Grewal has over 35 years of professional practice, establishing Grewal Eye Institute as a premier ophthalmic hospital in Chandigarh. He has won numerous awards and recognitions and has more than 150 publications in national and international journals. And he has keen interest in software development and proponent of paperless working and seamless integration of IT in patient care. So it's wonderful to have you, sir, in this webinar.
It is a pleasure and a privilege to introduce Professor J.S. Tityal, Professor and Head Cornea Cataract Refractive Surgery Services at RP Center for Ophthalmic Sciences, All India Institute of Medical Sciences, New Delhi. He was awarded the Padma Shri by President of India in 2014. He's also the Chairman of National Eye Bank at RP Center, AIMS, New Delhi. He has more than 200 publications in the peer-reviewed journals and has authored 2 books and 27 chapters in various books, including the very recent book on smile technology. He has to his credit numerous presentations, live surgical demonstrations, instruction courses at international conferences, which include the American Academy of Ophthalmology, the ASCRS, ESCRS, Asia Pacific Academy of Ophthalmology, the APACRS, as well as the All India Ophthalmological Society. He was the first Indian to perform live surgery at the American Society for Cataract and Refractive Surgery conference, and he has also been honored with the Achievement Award by the Asia Pacific Academy of Ophthalmology in the year 2015 and AO in the year 2009.
Another very dynamic and excellent speaker who is a part of this webinar is Dr. Sri Ganesh, who is the Chairman and Managing Director of Natal Dhamma Hospital Private Limited and Managing Trustee Shraddha Eye Care Trust, Padmanabha Nagar, Bangalore. He had his basic medical education in Bangalore, and then he completed his postgraduate training at RIO Bangalore. He completed DNB, and then he was Observer Fellow in FACO and LASIK at Shepherd Eye Center, USA. Sri Ganesh's main interests are cataract and refractive surgery, and he has been in the forefront of latest technologies for FACO and refractive surgeries. In the field of refractive surgery, he's one of the few persons to start SMILE, LASIK wavefront surgery, phakic IOLs, toric ICLs, conductive keratoplasty, etc. He has received Best Phaco and Refractive Surgeon Award for the year 2006 from IRSI and has given live surgical demonstration for Phaco and LASIK at various places, at various conferences and guest lectures in various national and international conferences, has many research papers and awards to his credit, both international and national.
It is my pleasure to introduce Dr. Ishtiaq Anwar, who's cataract, refractive, and glaucoma surgeon and consultant from Bangladesh Eye Hospital, Dhaka. He did his post-graduation from Bangladesh College of Physicians and Surgeons and Cataract and Refractive Surgery Fellowship from Ila Devi Cataract and IOL Center in India. He further has done his glaucoma fellowship from Arvind Eye Hospital and Institute at Madurai and has an international fellowship on glaucoma from New York Eye and Ear Infirmary, USA. He served in different capacities in different hospitals, which includes the 500-bedded National Institute of Ophthalmology at Dhaka, and his interests are practice of new technologies in ophthalmology, education, and community outreach programs. He has a special interest in teaching, training of phacoemulsification in Bangladesh Eye Trust Hospital, and he does phacoemulsification surgeries, glaucoma surgeries, and LASIK surgeries routinely, but has special interest in managing complex cataract and glaucoma cases. And his mission is to provide highest standard eye care with passion.
We have a young and dynamic speaker in Dr. Naren Shetty, who is currently Head of Department of Cataract and Refractive Surgery, Vice Chairman of Narayan Netralaya, Bangalore. He completed his basic medical education at SDMMCH, Dharwad, and did his residency from Ramaya Medical College and Hospital, Bangalore, MS Ophthalmology at Bangalore again, and cataract and refractive training at Narayan Netralaya, Bangalore. He has worked under cataract and refractive surgeons of Moran Eye Center, USA, and SNEC, Singapore. He is a very experienced surgeon, both cataract and refractive, and in a very short span of time, he has done more than 13,000 cataracts and over 700 refractive surgeries. He has presented numerous papers in both international and national conferences and has various publications in peer-reviewed journals. He has won the Best Postgraduate Scientific Paper Award in the State Conference of Karnataka, and he has won the Travel Grant Award in the International Conference of ARTEVO, and has for his paper presentation in 2015. He has participated in many live surgical demonstrations in various conferences, and Dr. Naren has keen interest in research, has been a part of various research projects which are being undertaken in Narayan Netralaya. Thank you, Dr. Naren, for joining this webinar.
With this, we request our first speaker, Dr. Grewal, to give his talk on digital 3D technology and ophthalmic microscope.
Thank you so much, Dr. Namrata. Is the screen visible and I'm
Yes.
audible?
Perfect,
Yes.
perfect.
Okay, thank you so much. My sincere thanks to AIOS and Zeiss for giving me a chance to be with you all today evening to share my experiences with the digital 3D technology as an anterior segment surgeon. Now, we all know that the stereoscopy is not something new. For the artificial stereoscopy, the concept was invented by Charles Wheatstone in 1838, so almost 178 years old thing. And the fundamental principle is to display an object from one angle to the left eye and to display the same object from a slightly different angle to the right eye, and the viewer's brain fuses the two images to create the stereoscopic effect. It is said that seeing is believing, and as an ophthalmologist, we all believe in that, but seeing more is believing more. And since eye surgery is only through the optical feedback, we don't have much of a tactile feedback for operating. The quality of the image is likely to affect the performance of the surgeon and finally the outcome of the surgery. There are a lot of advantages which we'll go through the presentation. It provides a new dimension of viewing experience to the ophthalmic surgeon, and the digital image processing allows us a greater magnification without loss of resolution. It also allows enhanced visualization of the periphery up to the ora serrata with good magnification. Does it have a learning curve? Yes, it has a little learning curve. We'll go through the steps as we move forwards, but the increased surgical duration is only for the first few cases. I'll say that from the second or third day, you should be back to your same surgical time as you were doing with the optical microscope. Just a brief about the Zeiss ARTEVO 800 system. It's a stereoscopic 3D image on a 55-inch 4K monitor, which provides you a comfortable heads-up position, and your OR team has a real-time stereoscopic view of the surgery. That means everyone in the OT can have the same view as the surgeon is having. When we are looking through an operating microscope, and that's what we had been doing throughout our life, it is like a tunnel effect. You just see the small area which is operating, and most of our field of view is dark. But when you move on to the 3D system, you escape from the tunnel, and it's an entirely different perspective right in front of you at a much higher magnification, and you stay connected to the surroundings also. One of the big advantages is that you can operate at low illumination. And it is possible to operate at low illumination because the sensitivity of the cameras that are used is much more than that of a human eye. Only 20 to 30% of the illumination intensity as compared to 100% in optical microscope needs to be used in this microscope. It makes it more comfortable for the patient, especially under topical anesthesia. And there are less chances of photic retinal damage in surgeries which have a longer duration. The image on the screen has excellent contrast, excellent color, and beautiful brilliance. And these are adjustable, but once the ARTEVO is installed and you have set it once, I don't think you need to change it ever again. Another big advantage is the depth of field, and that is what we are interested. We have all worked on the initial microscopes where where you initially like I started on a Zeiss microscope which had a fixed magnification and a fixed focus and no foot control. And starting from there, we realized that we need a foot switch so that you can keep on moving up and down because the field was limited. But in ARTEVO 800, the depth of field is amazing. You need not struggle with the focusing. Once you focus at the beginning of the surgery, you can complete the entire cataract surgery without requiring to adjust the focus again. And it gives excellent stereopsis. And one beautiful thing about the ARTEVO is that the stereopsis can be recalibrated as per surgeon stereopsis. The cameras have built-in smile alignments so that you can, when the ARTEVO is installed, you can get it accustomed to the kind of the stereopsis you are looking at. Now, this is very interesting. We all know that as the magnification is increased, the field of view reduces and the depth of field also decreases a lot. Now, that is one point where ARTEVO really scores because it gives you a combination of big field, it gives you a combination of depth of field along with better stereopsis. Now, that is something which you will realize that when you are operating, you are seeing the eye much bigger than what you are used to under the optical microscope. you will see that the depth of the field is much better and you don't have to adjust it during the surgery. And the stereopsis is excellent. Less esthetopia is another advantage as the surgeon does not accommodate while viewing through the eyepieces for a long time, as 3D system does not require near vision. It does not need the eyepieces to be adjusted for that. And the ease of the working at high magnification is really great. And even if the microscope setting says 8x or 10x or 12x or 16x, uh, operating at the same microscope magnification through the optical system versus on to the digital 3D monitor, again, is a different experience because you get much more relative magnification as you are operating. You can see those fibrils dancing at the posterior capsule, and these kind of a magnification and detail I had never experienced with the optical microscope. And this is the magnification at which you can go. You can work on that magnification. And it is so interesting to realize that the tips of the instruments appear so different under the ARTEVO. This is the sandblasted tip of a bimanual IA, which I never realized that it has a surface like this until I started using the ARTEVO. Is there any lag? Because theoretically, you have a camera capturing the image. The image of the operating eye is not coming directly to your eyes. It's going to the camera. From the camera, it is going to the computer. From the computer, it is being processed. Then it is being displayed onto the monitor, and then it is coming to you. So one may feel that there may be a little lag when you are operating going through this additional system, but there is actually no lag in the display. There is a little lag in the illumination compensation. That is, if the illumination changes, then the system takes a little time to adjust to it. Does it make any difference in the cataract surgery? No, because during our cataract surgery, our field, our magnification, our illumination remains constant throughout the surgery. So it doesn't make any difference of this lag in illumination, except in some situations where you have a very highly reflective instrument coming into the field, which gives a greater light, and you may feel the background becoming a little darker for a short time. Changing field illumination sometimes poses issues in retinal surgery, especially when you are working in the periphery. So ARTEVO leads to a complete change in the perspective in a way which you are operating. Now, in the learning curve, is there any recalibration of the coordination required? The truth is no, because as an ophthalmologist, we are already using an optical microscope. We are looking like this and operating with our hand down. So this way, there is already our eye-hand coordination is already dissociated. So we are looking somewhere else and we are operating somewhere else. So there is already a dissociation between our eye-hand coordination. So it comes quite handy when you are using ARTEVO, because all the adjustment that you need to do is here, move your head a little to the side so that you are looking at the monitor, which is placed right aligned to close to the operating microscope. This is the only change that you need to do when you're moving from an optical to a 3D system. So a short learning curve is achieved ability to direct instrument to incision without looking down at the eye. So this also will take 2 or 3 cases. Within 2 to 3 cases, you will be looking at the monitor, you'll be holding the instrument from the assistant, and you will be able to direct the instruments right into the eye without looking where the eye is. So that step didn't take much of a time to learn. Another big advantage is ergonomic advantages. We all know that the surgeons have a higher incidence of their spine problems, backache problems, neck problems, and upper extremity symptoms. And they are seen in almost up to half of the surgeons operating over a number of years. And this is because we have the patient's eye, operating table, and the operating microscope, and we have to look through the binoculars. We are forced to adjust our position and bend forwards to look through the microscope. With the ARTEVO, you are sitting back. Your head is completely dissociated from the operating microscope. You have a superior back and neck comfort. It's easier to keep your back straight as you can move your head away from the eyepieces, and you don't have to lean forward for this. It is an aggregate of small things which make the final impact. Before surgery, when you are going to start the surgery, you adjust the stool height. You look at the foot switches, are they comfortable or not? You look at your patient's eye position, and you have to adjust your head also to the operating microscope. Now, this becomes a little issue. If somehow we could take one component which ARTEVO takes out, then it completely dissociates all these things, and you can have a position which is comfortable and you're straight back. And it is a hybrid mode. Like in beginning, I didn't have that issue at any stage to shift from the digital to the optical mode. Right from my first case, I have been doing all the cases onto the 3D only, but it has an optical mode. There is a small switch. You just flip the switch and it changes from the digital to the optical microscope. Now, I think that is a huge advantage. If there is some things is there or some situation where you want to go to the optical, it is just at the flip of a knob that you can go through. Another advantage of this system is if there are multiple surgeons operating in the same room, which is always there in the organizations, there is no need for IPD setting. Otherwise, every time you sit on an optical microscope, you will adjust your IPD, then you will adjust the refractive error to your thing. You'll adjust the eyepieces for refractive error. If you're wearing glasses, you will go to the high eye point setting on the eyepieces by screwing them out. And there is no need to adjust the inclination of the binocular. So a shifting between the surgeons is seamless kind of a thing with nobody has to make any adjustment for that. And that becomes excellent in the training also, because when you're training the resident, there will be many situations where trainer may have to intervene and the trainee has to get out of the stool and surgeon has to take over. Now, in that situation, the switchover is so quick because the surgeon is already viewing the same view. He has to just sit on the stool and continue with the steps of the surgery. The training is not limited to one resident at a time. So if you have 10 residents in the OT, each one is getting trained at that time. And it is far more comfortable for the assistant, enabling them to pay better attention to the surgical step. It's very important as an assistant, if you are assisting in vitrectomy, you have to bring down the lenses in position. So it becomes very easy for the assistant to get the things quickly and accurately and precise in focus for the surgeon. And advantage of stereoscopic videos to improve the understanding of the surgical steps and enhance the learning of the new residents. There is excellence of reviewing of the surgeries because stereoscopic view improves understanding of instrument handling for the residents. We found that after moving on to ARTEVO, the incidence of complications by the trainees has come down, and these trainees are who have done just 3-4 cataract surgeries before they come to us. We are part of the resident training program for Northwestern University. So it definitely has a tremendous effect on the training, and these are the reasons which I've already mentioned. We went through our data because we have the actual surgical time data for all the cases for many years, and we found no statistically significant difference in cases operated on ARTEVO or operated earlier on the digital microscope. This has the few views from the OT. This is the trainee operating. Again, it's very comfortable. They don't take much time to move onto the system. You stay connected to the surroundings. This is a tracheum surgery. This is how it is recorded. The stereo surgery is actually recorded like this. And when you display it on the 3D system, the monitor combines these two images into a 3D image. And it does have, this is the view from one of our consultants, Dr.
Zeiss ARTEVO surgical visualization system at our institute for the past few months now. What I would say is the learning curve is quite short, and we were able to adapt after just a few cases on the machine. In terms of average duration of the surgery, it didn't differ significantly from that performed on the standard operating microscope and had minimal intraoperative complication owing to the excellent depth perception, better screen parameter control, wherein one can change color, contrast, brightness, gain and hue, and even regulate the white balance, which helps enhance the surgical performance. The surgeon also to maintain a comfortable, stable position and carry out surgical prolonged procedures, reducing the musculoskeletal fatigue and strain, which may have compounding effect over the years, and certainly improved ergonomics. And it also helps as an improved tool for teaching of intraoperative surgical procedures. Your assistant can also see better, hence assist better. And overall, it's an evolving technology that is relatively easy to shift on to, and you can manage most of your vitreoretinal procedures using this.
So there are additional digital operating tools, which is the cloud system, and the use of the Toric, the Callisto on this is a much better and more accurate system than our experience with the older system. And I'll not be going in detail because we have a talk on this later on in the session today. So improvement over the time, are there some things which I would wish to have in the future? Better and faster auto iris control, improved software calibration for the images, maybe built-in thermal cameras, maybe fluid flow highlights, maybe posterior capsule analysis, or maybe intraoperative warnings using AI, or a dye-free capsular staining by using different wavelength of light. So there's a lot of potential and the directions in which our surgery may change over a period of time once some of these things are taken up by Zeiss. If you are going in for the ARTEVO 800, are there any changes that you need to make in the OT or anything you need to aware of? Yes, you have to modify the OT setup. And the main difference is that you need to make a space to put that 55-inch monitor trolley. You need to upgrade your recording system and storage solutions because the 4K stereo 4K recording takes a huge speed, huge space. So you need to have a faster system of downloading the files and a huge space to store all your surgeries. And you need prescription 3D glasses if you are a myope. So that is again something very important, that when you order ARTEVO, please get your prescription 3D glasses. Training of the OT staff is not much of an issue. Involvement of the OT staff definitely improves. The assistant is really in a much better position to help you out in the surgery. All can see what you see. That's another thing. And the best is you don't feel that you are operating. I had been using, because of my backache problem, I had been using a belt during surgery for all the years, but within 2 months after changing to ARTEVO, now that is just hanging in the changing room in the OT. I haven't used it now for almost a year and a half or 2 years. So the days of only the surgeon enjoying the surgery in the OT are over. Everybody is enjoying now the surgeries. And one confession at the end before I finish my talk, I'm very possessive of 2 things in my life. First is my Porsche Carrera 911 and my ARTEVO 800, both ultimate player. Thank you so much.
Thank you so much, sir, for that fantastic talk on ARTEVO, which covered almost everything. And I'm sure there are going to be questions, and I think we'll take the first set of questions after the next talk. I would now invite Professor J.S. Tityal, who's going to be giving his views on the digital operating microscope.
Yeah, good evening, friends. Namrata is visible?
Yes, sir. Perfect.
Yeah. First of all, I'd like to thank AIOS team and the JAIS people for organizing this wonderful session on digital technologies. I think entire surgery, not only the ophthalmic surgery, most surgery done in a body has become digitalized. And we are not far behind in improving the outcomes of various ophthalmic surgeries with digitization. So I'm going to talk about the workflow of cataract surgery with new digital technologies which we have with us. As far as financial disclosure are concerned, I have no financial disclosure to be made. We have been employed by the government sector, All India Institute of Medical Sciences. Let me take you through this presentation in 3 segments. So if you look into workflow for cataract surgery, there will be 3 things. One is the pre-operative assessment of our cases. And what about intraoperative features with digital systems? And ultimately, the post-op assessment for looking for outcome, satisfaction of our patient after doing surgery. So let me take you the first thing, which is basically the work of a patient, which is now becomes so accurate with optical biometries and the aberrometry analysis of these patients. Then most importantly, the data transfer of these diagnostic to the operating microscope for your surgical enhancement. So effectively, we can say today the cataract surgery has become like a refractive surgery. It's mainly because of availability of these technologies, which made things possible for us to calculate in a manner which will give you ultimate results. So this is how I'm going to take you through the initial things, which will be basically looking for IOL Master 700, ray tracing of cataract patients to get aberrometry of the eyes, and how to get the data transferred to have a surgical precision and accuracy in the operating table, and the final outcome in the post-op period. IOL Master 700, we all know, is the latest technology in optical biometry, which gives a telecentric keratometry to give you a better assessment of a corneal as such, and the attachment of sweat source OCT, which provides the total K, which also encompasses the both anterior and posterior corneal curvatures. We all know posterior corneal surface has become very important since we have been working on a toric IOL outcomes. Now we know that posterior corneal surface has to be assessed to achieve a good outcome in a toric IOL implantations. Once we have a swept OCT attached in IOL Master 700, that effectively calculates the entire both anterior and posterior surface, gives you a total keratometry, which is basically takes away the calculation which were made initially to presume how much will be the effect of a posterior corneal curvature in ultimate IOL power calculation. So that's the advantage of having combination of IOL Master, which has telecentric 3-zone keratometric assessment of anterior cornea. With the OCT, get a nice posterior surface assessment of these cases. And TK will give you a better assessment for, especially for IOLs power calculation, which are looking for cases with toric IOLs, and especially now with the trifocal toric lens, so you require a very accurate assessment. And most importantly, the post-refractive surgery patients, where we do have major challenge of assessing the corneal toricity or corneal power more accurately, because after refractive surgery, both anterior and posterior corneal curvature would change. And the tools which we had earlier may not give you a true analysis of posterior curvatural change after refractive surgery in these corneas. So this IOL Master 700 gives you a true K or a total K, which will give us a good assessment of IOL power calculation in cases of post-refractive surgery patients. So if you have IOL Master 700 as an interface, what all things can be used to get a good outcome in your patient. So basically, it is the integration of pre-operative assessment with IOL Master 700 and transport this data to the operating table. So basically, it is an Ethernet port which is connected, internet connected with the system to the printer. And the software can also be there. The data interface is electronically can be transferred to your operating system, especially Microscope, where it can be computed to assess your Callisto eye. So that toric IOL alignment can be easy. So either it can be transported by your USB port, or you can have a forum attachment where you don't require to take any data with USB. That makes the surgical area much simpler. Your workflow can be much simpler and no disparity. Sometimes you can have multiple data in one system, and that can confuse sometimes your toric IOL calculation also. So I would say if you have a forum, that makes things better in terms of managing your workflow in the OR. The second important thing, digitization of a pre-op workup would be assessing the abrometry, especially looking for a angle alpha or angle kappa. Angle alpha will be much more important for a IOL implantation, both for a toric as well for a multifocal or trifocal lenses. So if you have patients with a high angle alpha, which is more than 0.5 millimeter, so these cases may be poor cases for a premium IOL. So this will sort out the patients which can have a post-op poor vision, especially they can have visual symptoms like halos and glare and starburst. So that can be avoided in these patients. So this has become an important assessment pre-operatively for all patients nowadays. The second important part of a workflow would be after you've done a good assessment of your patients clinically in a pre-op section, the data has to be transferred into an operating microscope. So what all things we can do there? So we have image guided systems attached like Callisto in a JAIS system, or you can have attachment of integrated intraoperative OCT, which can give you a true dynamicity of changes happening during your surgery. It can also give you sections of your structure, so you can know what morphological changes you are seeing in your patients, especially if you're doing a cornea or retina surgeries. It is also useful for cataract surgery also. You can have intraoperative abrometry based calculation of IOL power or a toricity or a toric alignments. And what we just heard the previous talk on the digital microscope, especially 3D heads-up surgery, which can also improve your outcomes to have a good post-op picture in these cases. So I would take you through the important area of cataract surgery, that is toric IOL implantation. We all are doing toric implantation for our patients because we know that anything more than one diopter cylinder in the cornea can cause a post-op poor unaided vision in your patient, and that can be a headache for a patient and for a surgeon also to explain why vision is not 6/6 without glasses. The toric IOL significance is there because we always have around 30 to 40% of patients will have at least more than one diopter cylinder, especially if you have a multifocal or a trifocal cases. This toricity, less than one diopter also, it should be corrected with toric IOLs. So basically, we have been taught we are going to see the astigmatic axis of patient in pre-op factor. The amount of astigmatism is with the rule, against the rule has to be seen. And on the table, you have to mark the axis, both reference and implantation axis accurately if you are using manual. But if you're using a alignment with a system, which can give you image guided surgeries like Callisto G Align or a Varion. These are two important systems we have nowadays in OR, which can help you, or you can have an intraoperative abrometry devices. We can also enhance the outcome for your patients. So classically, we have been doing a 3-step procedure that is going to give, as I said, 2 3 reference marker, then intraoperatively axis marking for these patients. And image guided modalities now we have. So if you see the various results analyzed in the literature, they would say visual acuity is always comparable with the various types of devices used for marking the cornea, and even with the image guided systems also. But if you look at the visual quality, which is the actual assessment of outcome of these lenses, is not well known for most of these cases with various devices. So these are various devices used for image guided systems. You have Osher's eye trace system can be used. As I said, Varion and Callisto are the one which are using very regularly, and most people are using these devices. You can have ORA or OptiWave refractive analysis by Alcon, which is based on an intraoperative wavefront refraction to calculate the power and see the alignment also. Just to show you what are the tricks we play in the operation theater. This is a patient under ARTEVO. So image guided system will give you an accurate incision placement for a main as well as for side port. And that is important because sometimes SIA would change if you change your incision. Never change your incision as per the axis. Maintain the same axis for a toric IOLs because the toricity is going to be corrected by IOL, not by your incision. This also helps you giving a good capsular axis size and centration, and that will be effective for placing lens effectively in a proper position. So once we complete the nucleotomy safely, you can have cortex aspirated. You all know for any IOL implantation, proper cleaning of posterior capsule also important. Viscoelastic has to be removed effectively both from anterior to the lens and from the posterior to the lens surface also, because the rotation post-op can be mainly sometimes because of a retained viscoelastic. So these three marks which you see with the jet aligned Callisto system is the central one has to be aligned to the three dots which are there in a optic haptic junction of IOL. Always keep the lens little away from the central area, anti-clockwise, hydrate the wound, make the chamber stable, then just tuck the lens to get these three dots in the lens to align with the center line of a Callisto images. You can see nicely centered images with the line. So this will effectively improve the outcome for your patients. But sometimes these lenses, especially open loop L-shaped haptics, are difficult to rotate anti-clockwise. So you have to make sure lens is well open. I can see that my axis is 111 degree here, well aligned. I'm hydrating the wound area. So sometimes during this procedure also lens can move. So it's gone away from my area. So I can't rotate reverse. I have to rotate entirely 180 degrees to come back to the area. I'll leave it little anti-clockwise, then subsequently place the lens after making a complete watertight closure of your chamber. To make sure you remove entire viscoelastic, maintain the antechamber integrity, then tap the lens in a position from the anti-clockwise to clockwise. So this is what I want to show people, that manual marking can be haywire sometimes. It is almost 5 degrees away from the desired axis. So I'm putting my own way to correct the orientation here. The marking has to be sharp and as clean as possible. If you have a wider mark, that can also take away your 1 or 2 degrees. So this is a sharp marking here, which is matching with the Callisto marking here. Now after surgery also, you'll see manual marking and the Callisto marking is also matching. So if you want to use only manual marking, you don't have image guided system, you can still achieve a good results, but you have to have a consistent marking by an experienced person in a patient. And especially if you have a 3 reference marking, that will give you a much better alignment and may take away the torsional effect also. This is our initial result of comparing manual versus image guided surgeries. And we found that image guided surgeries would be definitely better. So this was a group 1 manual marking and group 2 Callisto marking, and had a significantly better relation of post-op assessment with eye trace, looking that in image guided system, we had lesser deviation from the main axis in these patients. And the other important thing was visual acuity were comparable, as I said in the beginning also. But once we looked into a modulation transfer factor function, which is basically the contrast of these patients, and point sweat function, both were effectively much better in case of the image guided surgeries. That shows that if you are nearer to your reference axis of implantation, your quality of vision of patient will be much better. This is a device which is attached to a femtosecond laser. And you can see here, this device gives you a little knob in the capsulotomy, and that can be a reference axis for implantation. So laser devices can also give you an enhancement of placing IOL in an accurate axis for these patients. This is one of a patient which is correctly aligned to the tongue, which is there in a refractive capsulotomy, and IOL can be implanted subsequently. Comparing Callisto versus Aura, and there are many reports out there. Callisto and Aura are equally good, but some studies would say Callisto will be better in some cases also. What about workflow with the ARTEVO 800 3D operating microscope? We heard Dr. Grewal taking us through the entire system. This is also a significant increase in the safety of yourself, patient, and getting a good results. This is our editorial we published in IGO, looking into its advantage in a current normal of working in a COVID time. We do have 3 viewing system, active or passive. What we use is a passive 3D system, where we use a heads-up system. We have 2 available in India, Ingenuity and ARTEVO cases. So this is what Dr. Grewal talked about. You can go to very, very high magnification of these patients. My illumination around 36%. You can see 17.5 time magnification. And despite this magnification, the image doesn't get distorted. Only thing, the movement of eye or patient can be magnified also. So you have to be careful little in these cases. So this is very, very advantageous. If you have a complication like PCR, you can see better and you can manage better in these cases. Second advantage is it also has Callisto aligned attachment. So after IOL implantation, especially for a multifocal, trifocal toric lenses, the alignment can be better done in these patients effectively because you have a larger screen to see and you can do better. Third is had an OCT attachment, and difficult cases like a white cataract, you know that what type of white cataract you're dealing with. You can assess the intraoperatively what type of fluid release you have, how much is the pressure release after your initial nick, all can be assessed with your IOCT attachment. The most important thing which I have seen is the patient, which Dr. Garewal talked about, the illumination in a topical anesthesia, patient may not be comfortable at all. You can see if I decrease my illumination, I can go even up to 5% illumination to make patient see better. You can see I'm going down now, working with a 5% illumination, patient now fixes and you can do a surgery comfortably. So that's the advantage of this system with this microscope. If you look into a Callisto system, because it is magnified, so you can see these three lines of Callisto, which is, you can say, minified in your screen. So this will also improve your precision in implantation of toric IOL because the lines are narrower. Your alignment will be much better in these cases. To compare Ingenuity with ARTEVO, ARTEVO is a integrated system which has a lesser lag than a Ingenuity. Therefore, it is a better system for anterior segment surgeries, though both are equally good for posterior segment surgery also. As I said, for a COVID time, the surgeon is also away from the patient's eye, and the residents can also sit at least 2 meters behind, and they can effectively see the entire surgery without creating a crowd in the operation theater. So that's a very good system in a COVID time also. And it's a unique in terms of ergonomics, which Dr. Garewal talked about. You are absolutely straight viewing the system, but there's a little bit angle from head to eye. This you get used to within a few surgeries. The only problem maybe is the assistant can have a larger angle for adjusting, and sometimes the sisters can have a little difficulty if you put the lights off. What about digital workflow in a post-op period? That is basically when looking of ray tracing aberrometry, toric enhancement softwares, which can also improve your quality of your assessment of post-op cases, especially with toric IOS. So this is what we use, iTrace, to look into your patients. Like this patient would require a rotation of 74 degrees, which will improve your cylinder effectively to a 3.14 diopter. So these type of things doesn't happen. This is a rare case which can happen with a rotation, a high myopic patient with a bag is large. So these cases you have to reassess, then subsequently rotate these cases. This is another patient, shows 25-degree rotation. The patient has a good visual acuity, 20-25, and shows that if you rotate, only 0.5 correction will be there. So you have to take a decision on this. Sorry. This is one patient, effectively no rotation required, 1 degree. And this is a software which is available with, www.astigmatismfix.com. You can analyze similarly in these cases also. To summarize, toric IOL, the prerequisite for in the digital time also is manual methods may not be good, but pendular methods are equally good. Image guided systems have really given a way for accuracy for our patients. Intraop aberrometry may help in some cases, especially post-refractive surgery cases. 3D head-swab display is helpful for surgeons. Sorry, with the enhanced ergonomics, especially the magnification, working with the OCT and toric image guided systems does help you in improving visual quality. Residents, I think, as Dr. Garewal talked about, it's very helpful for teaching. A large number of people can see at a single time, and they can assess themselves, seeing the surgeon, and improve their surgery also. The institution where we have more teaching, these devices seem to be a must in future. For nursing staffs also, they can see the surgery, what is being going on, and they can assess better. But sometimes if the lights are dim, they can have difficulty in, especially they're loading the IOLs. Digital outflow improves the workflow for our patients, both intraoperative, where we have advanced diagnostic like IOL-Master 700, which gives you formulas which can effectively be used for difficult cases like post-refractive surgery patients, ray tracing abrometry. Intraoperatively, they can be integrated to an image-guided system, IOCT, and abrometry. And basically, the entire pre and intraop can be integrated by seamless transmission to forum. And post-op assessment is also digitalized nowadays to get a good results for our patients. Thank you for kind listening.
Thank you so much, sir, for that comprehensive digitization of the entire cataract flow. And I think that is going to be the future. I would now request Dr. Sri Ganesh to give his talk, and his talk is going to be on ARTEVO 800, interesting surgical videos. There is a question both for Dr. Grewal and Dr. Tityal, sir, and I think sir did answer this in his talk, and that is that there is some amount of tilt which happens, because when you're especially operating temporally, and if you're not doing it superiorly, then there is a tilt which happens, and there is an angle which is present between the between actually the monitor where you have placed as well as between your neck. So how do you compensate for that, and do you get used to it?
As both me and Dr. Grewal talked about, definitely there will be some tilt in terms of your vision is concerned, but your body position is absolutely straight. So what I have measured, it ranges from around 7 to 10 degrees from the axis you have for microscope with the patient's eye. So that is compensated by, your hands are actually in the patient's eye state. That we are always, we are potentially been trained into being straight to the patient's position. Your hands are absolutely straight to the patient eye. It's only your eyes are which is little away to the screen. So that you get used to. Only problem which I have faced now, like since we have this system, I have only done surgery in headset. Once you go back to the operating microscope, everything looks very, very small. It's like shifting from a naked eye to microscope surgery. Microscope gave so much of magnification and better visibility. Same thing now, shifting to ARTEVO headset device, it gives us so much of clarity, the magnification. Once you shift to microscope, everything looks very dull. So that also people have to get used to.
I think that is what I wanted to point out also when Dr. Grewal sir was, talking, that it's okay to teach residents, it's okay to make them learn on this, it's okay to make them do the surgeries, but what will happen when they go out from our setups and open up their own practices and suddenly find the whole world so minified? So that is a problem with us. We are just between the magnification and the minification because we are used
But
to it.
I'm pretty sure because people are going to come out with these devices. As we found that it gives you so much of a clarity and magnification, and your surgery improves faster. So I'm pretty sure training will also become much better with these systems, and most microscope in future will have this device attached. So and prices will definitely come down.
And
Just
I'll add that over a period of time, the price is definitely going to come down. Can I add one thing to the question about the angle? It's already answered, but one thing is that if you are right next to the microscope, the change in angle appears a lot. But when you move back, that angle becomes very small. And as Dr. Tyal said, it's only 7 to 10 degrees, which is not significant. It will appear significant if your eyes at the microscope when you are looking at the monitor.
one additional thing what I felt while doing surgeries in this system is that your recording is very good and very well centered, and you can monitor that yourself, and you don't have to depend on your assistant for monitoring that. So that is also an additional advantage which I felt apart from so many good things.
Rajesh, I think point well taken, because the things are magnified. If the patient is not well centered, the clarity goes down. So you have to be centered almost every time. So it is little more sensitive where your axis is a little deviated. In that way also, you are always going to do a coaxial surgery for your patients.
I do feel that when you do ocular surface surgery, sir, and I think I've shared this with you, it is a little tricky because you have that whole wide field in front of you. And it's a little tricky as compared to when you would do it on a operating microscope, which doesn't have a RT system, because you don't need that much.
Yeah.
Everything, kind of gets expanded. For eye, it is okay. For intraocular surgeries, it is fine. For your lamellar surgeries and all, also probably it is fine. But when you have to address the ocular surface, then it kind of gets massive. Sri Ganesh, can we have your talk, please?
Yeah. Good evening, dear friends, and thank you, Dr. Namrata and Zeiss, for inviting me to share some interesting cases with the ARTEVO 800. We got the ARTEVO 800 almost 1.5 years ago. I was involved in the R&D of this microscope, and we got the first installation, actually the first global installation of this microscope, and I've been using it ever since, and I got so used to it that I don't use the oculars anymore. And I think the previous speakers have covered the technology and the advantages of this system. But I'll just show you some interesting cases which I did this week. And let me just share my screen. Okay, I am a consultant to Carl Zeiss Meditech, and I'm also involved in the development of this product. And like Dr. Tityal and Grewal were discussing, of course, there are a few things you have to turn your head slightly to the side, and this is a higher-end microscope, but I'm sure in a couple of years you will be seeing something different coming up, which basically takes care of all these issues. And of course, I can't speak too much about it, but development is underway. So let me show you 3 cases that I did this week. The first case was an interesting case. I had operated this case as a patient of high myopia. I had operated 11 years ago. He came back with blurring of vision since 2 weeks, and this was the condition. The whole bag and IOL complex was just floating in the anterior vitreous. It was dislocated. So I put in a trocar cannula there, and I decided to refixate this lens. You can see it's a 3-piece lens. It's an SI40 lens. And I'm refixating it with a modified M&A technique just through 2 1 mm side ports. So this is interesting. This is, of course, the ARTEVO system. You can see I'm just using 13% light, and I hold this, I make the side ports, I hold the lens and the bag, and then carefully bring it into the anterior chamber. You can see the clarity and the color of the conjunctival vessels. The conjunctival vessels are focused, the iris is focused. So this is about 7x magnification. And this again, I'm doing with the 3D system. This is a complex case. So it's not only for routine cases, but complex cases also. I bring the whole lens bag complex into the anterior chamber. You can see the sommering ring there. And because of the high myopia, weak zone use, this lens bag complex are dislocated. I do an anterior vitrectomy. I remove the posterior capsule, and then I'm with the vitrector, I'm basically chewing up the sommering ring there. And after that, I kind of separate the anterior capsule and release it from the lens. Now I have to skin the capsule from the IOL so that the IOL is free. So I take a Sinski there, and then you can see that, like Dr. Rajesh was saying, it's always centered because you have to be centered when you're doing the microscope. And the recording in HD is excellent. So you can see very well. Your residents also can have the same view as a surgeon. So I'm just kind of releasing the capsule from the optic and also from the haptic. There I go there, and then now I have released it and separating all around with the Sinski. And you can see that now I've released that. This is a silicon lens you can make out from the shiny surface. This is an SI40. In very high myopes, I think it was +2 or something, the lens power. Very high myopes, you can have wigs on use over a period of time. You can. So I'm using this MST forceps to gently release this adherent capsule from the haptic, because the haptic has to be clean. Otherwise, you can't insert it into the needle for a M&A technique. So all these maneuvers are done just through 2 side ports. And you can see that visualization is excellent. You're sitting up straight, you're looking at the screen, and then you can even do all these small maneuvers. So then I separate it. Now the other haptic has to be released. You have to kind of skin it from the other haptic, the capsular bag. It's quite adherent because it's almost 11 years since the first surgery was done. So I just kind of pull it and then skin it off, and there it comes out. So the last part at the edge of the haptic, which so you can see that now the lens is free in the antechamber. I just remove the capsule. So then I go under the lens and do a vitrectomy, anterior vitrectomy, to clear the vitreous there. Then the pupil is small now. It's just a 2.5 millimeter pupil. So I use an iris hook. And then I put the iris hook on the right side. And then I mark the diametrically opposite marks. I use a Mendes marker, and then 1.7 millimeters diagonally away, I put the 2 marks where I have to pass the needle. This is a 27 gauge BD needle, which I bend, and then I pass it on the right side, conjunctival transscleral for about 1.5 millimeters, and then enter. And you can see the needle has come under the iris. Then I go through the other side port with the MST forceps, cannulated forceps, hold the haptic. The depth of field is excellent and the visualization is excellent. So you can do all these maneuvers also, then pass it, railroad it through the 27 gauge needle there. Then I pull out the needle on one side and just leave it there. You can see that. I just leave the needle there. So because I want to check the centration, because if you flange it, then if it's not well centered, again, you'll have a problem. I remove the iris hook there. And I put it on the opposite side, on the other side port. Retract it. This is again so that you don't have to manipulate the haptic a lot, because if you manipulate the haptic, it may twist or bend and then you don't get a proper alignment. Then I pass the 27 gauge needle, again, go under the iris there. I'm able to see it very clearly because of the retracted iris. Go and hold the haptic with the MST forceps. And then it is a little tricky, but I thread it through the first time is a miss, second time I get it in through the needle. And then gently pull it. The pupil is small, so you have to be a little careful, but the IOL again slips under the iris very easily now. I hold the haptic which has come out, and with my left hand, I remove the iris hook. Of course, being ambidextrous kind of helps in these situations. Then I flange it with the thermal cautery. So you get a flange again there, nice flange. And you can see that the lens is very well centered. Then I go on to the other side, release it from the needle. Hold it. Actually, this patient was one-eyed because the other eye, he has myopic degeneration and a foveal scar. So I wanted to do this minimally invasive technique. And again, flange it. You have a nice flange there, adequate flange, and then you just bury it subconjunctivally. And that's basically the procedure where you have refixated the IOL through two 1 mm side ports, minimally invasive, and then you can remove the trocar cannula. You can see the lens is very stable. Just hydrate the side ports a little, and then I remove the trocar cannula, self-sealing, and that's the procedure. This is the coaxial illumination, stereo coaxial. You can see that lens is very well centered. So that is the first case. And the second case is a case of nanophthalmos. This was a patient who had multiple angle closure attacks, about 7 millimeter axial length. You can see this posterior synechiae. So after giving mannitol and atropine for 3 days, we gave atropine for 3 days, pre-op mannitol. Here I'm doing sclerotomies, 2 sclerotomies in first temporal and temporal, and then I always like to do sclerotomies in such cases because you have a very high risk of effusion. 50 odd years old female, you can see I just incise with a diamond blade. The sclera is very thick, almost 2 millimeters. I go in with a Desmace punch and then punch it. So I have a nice opening. If at all there's a effusion, choroidal effusion, then this takes care of it to sclerotomies. You can make 1 or 2 sclerotomies. And then after that, you can proceed with the surgery. I make a side port, put in viscoat here. I'm using you have to use a good viscoelastic. The ACD is just 1.5 millimeters, so it's quite tricky. Then I have to release the synechiae. So there's a very high risk of choroidal effusion and malignant glaucoma. So you have to take precautions to overcome these two issues. And you can see that because the depth is so good, though the AC is so flat, 1.5 millimeters, I'm able to see with all the clarity. And then this is the main entry. I make a slightly trapezoid incision because the lens is quite thick. It's a 48.5 diopter lens. And I use the Malligan ring because these irises typically are very floppy. And then you can have floppy iris prolapsing, and then you get into a fix. So here I'm using the Malligan ring. Actually, there's no space there. I just put the ring on the iris and then I'm manipulating it to engage the pupil so that I have adequately dilated pupil, which is not floppy. And you can see the cataract also is quite dense. So you have to use a good viscoelastic, viscoelastics. And then I'm doing the capsular rhexis. Again, these cases, the antercapsule is very convex. So I use a rhexis forceps rather than a needle. It's very difficult to do the rhexis with a needle. Aim for a 4.5 to 5 millimeter rhexis. And that's the completion of the capsular rhexis. And after that, very gentle hydrodissection. See that the nucleus does not pop. Otherwise, very little space there. And then I make the other side port. And I go in, you have to increase the IOP. Here I'm using the Centurion. I increase IOP to 50 millimeters of mercury. And then that's the phaco chop. And you have to do the surgery quickly because again, if you take more time, the risk of choroidal effusion, expulsive again is higher. There's an older patient again, hypertensive, multiple angle closure attacks, glaucoma. You can see that an iridectomy has already been done. So this is management of the nucleus. chop and remove the fragments. That's the last fragment being removed. And always put in visco before withdrawing the probes. Maintain the chamber always. Otherwise, if the chamber collapses, even on UBM, the patient had an anterior rotated ciliary body. You have a very high risk of intra-malignant glaucoma aqueous misdirection. So always maintain the chamber. That's the cortex being removed. Again, put in viscoelastic, remove. You can see this is a custom-made lens, 48.5 diopters from IOCare. So we put in the lens into the capsular bag. And you can see that once you put in the lens, I find that the capsule is very flaccid. And I do a secondary capsulorhexis because I don't want capsular contraction. Because once you remove that large nucleus, the eye is so small, definitely you'll have capsular phimosis. So that's a secondary capsulorhexis. And then I remove the Maligan ring. And you can see that the chamber has deepened very nicely. And then I go in with a vitrector. I increase the size of the iridectomy. Then I do a zonulotomy and a hyaloidotomy. And so that there is a connection between the posterior segment and anterior segment. This prevents the risk of malignant glaucoma. Again, malignant glaucoma risk is very high in these cases. So it is one chamber there, and then I just hydrate the wound. You can suture the wound if you feel that it's not holding. That's the end of the procedure. I just close the conjunctiva where I've done the sclerostomies. And that was management of nanophthalmos, and this patient is doing very well. We're following her up. I think first day visual acuity was 6/18 because these patients don't improve fully. This is another interesting case which I did, an ICL, and you can see that I make a single incision for the ICL. This is a 2.8 mm incision with a diamond blade, intracameral xylocaine. Then this is my cannula, which I use to inject viscoelastic. I'm using sodium hyaluronate 1% there, and then I inject the lens into the anterior chamber. And again, you can see the ARTEVO 14% illumination. You can see that the glow is so good, retroillumination. I'm tucking the haptics through the main incision itself. I don't make side ports. This is the Ganesh ICL manipulator, which is available with Epsilon. So you can even inject viscoelastic to maintain the chamber, deepen the chamber, and the undersurface of this cannula is sandblasted. So you can, and it's got a curve so you don't touch the central area of the lens, and you tuck in the haptic. Once I'm done, okay, the ICL is, so everything is going on well and everything looks okay. But then the ARTEVO has the IOCT. So after I remove the viscoelastic, I'm just aspirating the sodium hyaluronate. It comes out as a bolus. It just takes about 15 seconds. You can aspirate it through the center flow hole there. And once that is done, then I just hydrate the wound. Okay, the case is almost over, but then I use my IOCT and then check the vault. And then you can see that we have a surprise there. Okay. So end of the case, fine, put on the IOCT now and to check the vault. And you can see that that's the IOCT, intraop-OCT. The ARTEVO 800 has IOCT, and you have a large. You can see the vault is almost about 1,100 microns. So you have a guide there also, 1 millimeter. So each segment is 200 microns. So you have like 1,100 micron vault. So what do we do now? So you can see what I do is I go in with my cannula, irrigating cannula, and I just rotate the lens. This is a non-toric ICL. So when you rotate it from horizontal to vertical, because the vertical sulcus is bigger than the horizontal sulcus. So I rotated it vertically. And then once you rotate it vertically, you can see what is happening to the vault. the vault reduces. And you can see the vault has reduced to about 400 microns now, which is perfect. So from 1100 microns to 400 microns. This is how the ARTEVO helps in ICLs. So you don't have to bring back the patient, exchange the lens, or again rotate it. So having an IOCT intraop is very useful in such cases. So these were the 3 interesting cases which I did this week, which I thought I would share with you all. ARTEVO system is excellent. You can see even at almost 10x magnification, you have both magnification and field, which you don't get with a regular operating microscope. You can see that the lens is focused, cornea is focused, you can see the blood vessels are focused. And of course, all the other advantages that were alluded by the other speakers. Thank you very much for your attention. If there are any questions, we can take that.
Thank you, Sri Ganesh. I think those were really 3 sets of complex cases which you read. And intraopacity was there with the case with the ICL vault. And so if you had an intraopacity, otherwise also without having an ARTEVO, that would help. But how do you think ARTEVO particularly helped in the complex cases?
Yeah, you can see that the visualization is better. So if you can see better, you do better. It's as if, why do we use an operating microscope? Because we want to see better. So with the ARTEVO 800, you have better illumination, you have better magnification, you have both depth of field and magnification, which you don't get with the regular microscope. You don't have to keep refocusing, that saves you time. And you can see even the smallest details very clearly. And that actually helps your surgery. Of course, longer surgeries, complex surgeries, you're sitting up straight and looking at the screen, very ergonomic, so you don't get any back pain or neck pain. Plus, these are cases where you have a lot of observers in the OT. All your fellows and residents want to come and watch it. And so even if there are 10 of them, then they can wear the glasses and they have the same view as the surgeon. And it's an excellent teaching tool. And as you can see that the recording, you get very high quality recording. And you can see the small details. So it's, and you're always centered, like Dr. Rajesh Sinha said, that you don't have to keep worrying whether you're centered or whether you've gone out of field. So that is, you get excellent videos for teaching, and you have 3D videos, you have 3D recording. So if you have the facility to do a 3D relay or a 3D TV, then it's excellent to show others and teach others the smaller nuances of managing these complex cases.
These files are quite big. So how difficult or how easy is it to edit these movies?
You have to have software which compresses these files, and then you can use that. So it is not a big issue, but then you have a 2 TB or a 3 TB hard drive where you put in all your recording and you edit it then and there so that you reduce the size. And then, of course, my surgeries don't need that much of editing, so that's a good thing.
It was almost all 3 were almost unedited videos, which you showed us. Another thing is that cases like you have Stevens-Johnson syndrome, ocular surface problems, patients are not able to open their eyes. There you could, decrease the illumination, like Dr. Chityal also showed.
Even otherwise for topical cases.
For topical cases.
Topical phaco when you're doing,
especially refractive surgery, where patient sees everything. It's not a white cataract, but patient actually sees the entire light going into his eyes. So
ICLs, basically all the light is going into the eye. So they're very sensitive. When you use a regular microscope, you have to use 25-30% illumination and they're squeezing against the speculum. Here you can just use 10% illumination. They're very comfortable. And you also have good visualization. And even topical phaco is much more comfortable for patients. Plus you have all the other assistance that you need for capsulorhexis, the Z-align for toric alignment. For LRIs, you have the markings. So these are all additional. And the other thing I find is for patients who have severe kyphosis, who cannot lie down, those who have breathing issues, then sometimes you may have to stand and operate. And that's when this helps, because you're totally dissociated from the oculars. So you can just stand, watch the screen and operate. And I have done so many cases like this. It's very comfortable for the surgeon, comfortable for the patient. And that is where in such cases, it kind of really makes a difference when you can kind of stand and operate. And irrespective of the surgeon's height, some of them are tall, some of them are short. And sometimes it becomes very difficult to adjust the microscope because they have to sit up, and then the table is hitting their legs here. Because you're dissociated from the oculars, the microscope can be at any height. And so you can make yourself comfortable to look at the screen. Even shorter surgeons are very comfortable using it. And you don't have to adjust the IPD every time. So basically no surgeon settings like that. Plus you have the EQ workplace and the Callisto, where you can transfer all the data seamlessly from IOL Master 700. You can put in your postoperative fractions. You can get your nomograms and your personalized day constant. So the whole host of other technologies associated with the ARTEVO 800, which helps you in your practice.
Thank you so much, Dr. Sri Ganesh. I now would invite the next speaker, Dr. Ishtaq Anwar from Bangladesh, who's going to be speaking about ARTEVO 800, the digital microscope, our initial experience.
Thank you and good evening, Professor Namrata Sharma and Professor Rajesh Sinha. And I also like to thank AIOS and Zeiss for arranging such a nice webinar. Am I visible?
Perfect, perfect. Everything is fine.
Thank you. So we have got this very recently, and we were eagerly waiting to use it. And as with new technology, this is just a journey, and this was a very good journey for us. We were waiting for it for a long time. And for any technology, it goes through adaptation. And what used to happen is that we used to get all these technologies once they were tested in the Western countries. We used to get it after many years, third generation or fourth generation, and we used to get all the benefits. But now scenario is changing, and we nearly order at the same time. So we are also going through the evolution and contributing to science. So why we wanted this microscope, as Professor Sri Ganesh says, is that, you know, what you see better, you can operate better. So viewing, one thing is that we wanted to see is clarity, the ergonomics, that we were all talking regarding how we had to sit straight with our back straight and our eyes fixed to the oculars for a prolonged time, causing neck and back pain. And the beautiful magnification that it goes up to, and
I think we've lost audio from Dr. Anwar. Is the audio on?
No, ma'am, the audio is off.
Now, Dr. Anwar, can you repeat? Dr. Anwar, can you write it on the chat, Sudhil, that there is some problem with the audio?
Am I audible?
Yeah,
Yes.
now you are audible.
Okay. So better depth perception and all the informations that we used to have in Callisto, like what the illumination, the magnification, what mode we were using. And this is an excellent technique teaching tool. So all the OR staff and the fellows can see whatever we are doing. So our experience, we had a big expectation. And when I saw first, it was just wow, that such big images that we can see with such clarity. But with time, we had to adjust some of the OR settings and how we were doing our operations. So this is a big screen, 55-inch monitor, and there is possible to go with huge magnification. It looks so big, the eye, and the illumination, as the previous speakers has said, that it can be as low as 5% of what we used to do. Like here, what we can see that the magnification is nearly 20 times. Still, there is no distortion of image, and the depth perception is very nice. So the learning curve, when we were getting it, every surgeon of our hospital was very eager to know that how it's going to be, how hard it's going to be adapt. And we had a live surgery just 3 days after we got it. And I had the opportunity to do one of the live surgeries. So I did just 2 surgeries before that day. And it was not that problematic. I could do a live surgery with a normal speed. And the other things were that where to set the monitor, how to sit, how much to tilt the head. All these things, I think, with 3 to 5 surgeries, it is possible to get idea and get accustomed to that. So the learning curve, I would say that it's not that much. And as the previous speakers have said, that we can do surgery in very low light. So there is less chance of phototoxicity, especially when the trainees are doing, they tend to take more time. The patient comfort is much more, and nearly it can be done at 1/3 of the light what we were used to do. The magnification is enhanced. The depth perception is not that much affected when we magnify it. And the resolution, as it has been mentioned, that is a 4K quality, beautiful resolution. I would like to just share 2 surgeries. And we can see that the magnification and all the add-ons here, how much illumination. I was initially using a little bit more illumination. So this is a lens I intended to do was a bag in the lens. So once the anterior capsular axis was done, we have to do the posterior capsular axis. And we can see beautifully even the wrinkling of the posterior capsular axis. So a nick is made with a lateral movement, and then with OVD that is enlarged, and the OVD is pushed into the burger space, separating the posterior capsule. And all this was visible so beautifully. Then a posterior capsular axis was made, in the similar size of that of the anterior capsular axis. Just for the sake of time, I would just go a little faster. This is edited. Once the posterior capsular axis was made, this is a special lens, Bill IOL, which was invented by Professor Mare Jose Tazignon. So we put both the capsular axis rim in the groove of the IOL. And we can see both the anterior capsular axis, posterior capsular axis, everything so clearly, and look at all the surroundings. And even up to 25%, 20 times magnification, it was so nice. And as Professor Titil was saying, that in PCT or other cases like this was one of my colleagues was doing this case where he intended to put a toric IOL and there was a posterior capsule rupture. So I took over and converted that rupture into a PCC. So this was a toric IOL intended. And what I would like to say that the magnification is 10 times, illumination is 45%. I could see the anterior capsular axis, posterior capsular axis, and place the lens in between those two. And as Professor Titiwal was saying, that we have a beautiful 3 lines which guides us where to put and place the intended axis. So just dial it and put them in that axis. So you can see that anterior capsular axis and the posterior capsular rent margin so nicely. It's so clear and visible even with that magnification. So when we got it, there was some apprehension regarding the latency, but as discussed earlier, it's only 50 microsecond, which is nothing that our brain can detect. So it's seamlessly, we can go along with normal thing. And the other thing is that there is something that Zeiss is calling hybrid mode, that we can put the ocular at any moment. If we are not comfortable and we feel that we need to use it, it's very easy. It does not take much of time. It takes only 30 seconds. You have to just screw it, and we can use both the ocular and the monitor is also there. So all the OR stuff can see whatever we are seeing through the ocular. But there are some little adjustment we had to make, as most of the surgeons now operate temporally. So for a right eye and left eye, the screen needs to be constantly moved and rotated. And we can't view exactly straight ahead, which we're doing till now. So this needs to be adjusted, and we have to tilt little bit to the right or left according to the eye. And I was trying to go close to the microscope, but I think as Professor Sri Ganesh said, that if we lean back a little bit, this would not create problems. So this was a good tip for me. I'm going to try the next day. So this is the thing what I felt, that lot of movement of the monitor was needed once I was going from left to right side. And there was so many wires, thick wires. And at times I felt this could be an issue with the sterilization. It can touch the trolley or something. So for maintaining an optimal viewing, adequate distance is required. It says that 5 to 6 feet. So we have to have a big OT for this. If there is a small OT and somebody operates, then this can be a point. And most of the cataract surgeons, as nowadays does under topical anesthesia, there is a lot of eye movement continuously and drifting of the head a little bit from side to side. And so it requires frequent recentration, because what I felt that the view when the eye is at center is best, and there is little margin of error with the, it's not same as that conventional microscope. So you have to be exactly at the center to get the best view. The other thing, the first surgery that I did, what we used to do is we used to fix up the microscope first and then set the table. So here I did that, and the table went so low. So this was the understanding for me, that first we have to set the table height at my hands level and then set the microscope height, because I don't have to put it in alignment with my eyes. So in conclusion, I would like to say that the learning curve is not that long. It takes usually 3 to 5 cases to get accustomed to all the change dynamics and position. And we did not observe any significant lag time. But what all the speakers are saying, that there needs to be little less movement with the fine focus. But in our center, what most of the surgeons are feeling, that we have to focus more rather than the conventional microscope. And in future, what we would expect is that the monitor should be wireless, so that when we are moving, we don't have to take all that wires, and movement of the monitor can be minimized in some way. And one other thing, that for any technologies to sustain, the cost is a big issue. So I'm sure in future this is going to come down. The best thing is that all the OR staff fellows are on board. They are seeing whatever I am seeing. And we have like 36 surgeons, and all of the surgeons have tried it, and all of them are just excited to use it, and they are doing very well. So what I request, that we can sit back and rest our back. Thank you.
Thank you, Dr. Anwar. It was a nice talk and very nicely presented your experience. We now move on to our next speaker, and we have Dr. Naren Shetty, who will be giving his talk on the topic that is Toric IOL workflow with EQ for optimal efficiency. Dr. Naren Shetty, please.
Thank you, sir. On this onset, I would like to thank AIOS and Zeiss for giving me this opportunity. So today I'll be talking about EQ workflow for a toric patient. So all of us keep striving to be efficient to save time and indirectly save cost too. But what is efficiency? Efficiency is doing better what is already being done. So what is already being done is we've been using all manual markers, but the errors happen because of there's no reference point. There's errors happen because of head tilt, cycle torsion, or sometimes when you excessively wash the cornea, then the markings go. As you all know, every 1 degree of misalignment of toric lens, we lose about 3% of its corrective effect. So when we use the routine 3-step technique of marking the toric, of marking the eye, first we mark the eye horizontally on the slit lamp. Then intraoperatively, we mark 0-180 on the eye, and then also the marking of the desired axis of alignment of the toric lens. So when we use this technique with the bubble marker, we have found that the mean error of axis is about 2.48, and also the total error in toric IOL alignment is about 4.98. So is there something better? This is where the Callisto comes in. So basically, it is a markerless system. What it does is it gives an intraoperative reference point for you to align your lens, but it has other features also. It compensates for the cycle torsion and gives you the right axis where you can create your incisions, your LRIs, and also do your capsular excess perfectly centered to the pupil or the limbus. And also it helps you in the toric alignment. So as you can see, I put a CTR in all my toric patients. As you can see, I'm doing it under irrigation. So once I've put the CTR, the trailing part, I hold it with a microforceps and put it into the bag. That way I'm rest assured it doesn't go into the sulcus. Now, why CTR? As you can see, there's a huge gap between the posterior capsule and the lens and the optic. This is one of the reasons why there is a higher chance of rotation during the early postoperative period. Now, when we implant a CTR, what happens is it expands the bag and brings the anterior posterior capsule closer together, thus increasing the contact between the optic and the bag. As you can see, this is a post-CTR implanted eye, where you can see a beautiful contact between the posterior capsule and the lens. It also has an automated tracking, so even if the patient moves his eye, the alignment or the reference points keep moving along with it. So this is how the overlay looks like, where you just have to align the toric lens according to the markings. Now, when we compare marker and markerless system, definitely I think in terms of quantity of vision, as Titi also rightly said, the quantity is similar, but definitely there is a significant increase in quality of vision, especially if you're going for a toric multifocal or trifocal lens. The patients will appreciate the difference between the two. And there are different studies stating the same. So now we have good hands and good machines. Is that enough? No, we need to connect them. And this should be a seamless connection. This is where the Zeiss EQ Workplace 1.6 comes into play. Basically, what it does is it seamlessly connects all the different machines in your hospital and brings it into one place. And it uses a platform called as Forum and connects all the platforms. So in the clinic, so what we do is once we do the biometry, the IOL master data gets transferred into the online, and not just the biometric data, also the topography, the OCT, any DICOM machines, you can use it and upload it online. And this can be accessed from any computer from anywhere. Now, the first thing what you do is you need to log in and you need to customize your settings. That means first you can choose the formulas which you normally use and also the IOLs which you normally use, and also the order quantity and also the emails you want to send your order to. So once you have done this, you don't need to keep repeating it, and it'll make sure that it follows the same routine. Now, coming to IOL selection. So once you have selected the IOL, you just have to add the IOL, and then you go ahead and then just go for the IOL order. Check everything and just press IOL order, and you're done, and you're good to go. You can also do your surgical planning. You can align your, where the lens should be aligned, your incisions and everything, and this you can transfer to your OT. Now, by chance you are not able to do it during your work time, let's say you have a long drive from your work to home, you can do it on your app on your phone. And while you're driving, you can just simply update all the data and do all the changes that needs to be done. Now, in the OT, when you select the lens, to confirm it is the right lens, you can use the same app. Once you scan it from your phone, and that way you will make sure that you're not implanting the wrong lens, as you can see in the image here. So post-surgery, one of the very unique features, you can personalize your IOL constant sitting at home or sitting at your workplace. So for any IOL in your hands, what is the most optimum is the A constant. You can really customize it when you add the pre-op and post-op data, and also put in the post-op refraction, and that way you can really customize and tighten your post-op results. Now, does all of this actually improve efficiency, or is it just a gimmick? So we did a study where we looked at the time taken before and after EQ workplace. So this is how the workflow normally goes before the before EQ workplace in the Markerless system, where all the scans are done, the printouts are taken, usually the calculations done by the fellows or the junior surgeons, and it is given to the concerned surgeon. Now, if the surgeon is busy, it might take even 30 minutes to reach to him and get him signatures, and then maybe it goes to the store department and purchase order. So the time taken might range from 8 minutes 30 seconds to 62 minutes 30 seconds. Now, after the EQ workplace and the Markerless system, so the time taken is just about 55 seconds to 1 minute 22 seconds. Now let's look at the intraoperative workflow. As you can see, this is how the normal workflow goes on. Not much of changes, but the place where we actually save time is during the marking, and also during the surgery. The marking, what you save is about 30 seconds, and then 7 minutes during the marking. So total of about 7.5 minutes in the intraoperative period you save. But we usually do about 100 surgeries per day. So that means we save about 750 minutes, which is a significant time which we save. And especially when your OTs are really busy, this will really impact your efficiency and make sure that you're giving a good experience for your patients. Now let's get into the patient's shoes. As you all know, or we all want a patient workflow. We don't want a patient workflow to be long and inefficient. We want a patient workflow to be short and sweet. So likewise, so when we look at the patient workflow for a toric patient without EQ workplace and Markerless system, first you have to instill a local anesthesia eye drops when you're working on the slit lamp, and this is not just once. You again have to apply it once more during your surgery. As you all know, the local anesthesia is pretty toxic to the epithelium, and the more you apply, it'll damage the epithelium and you have punctate epithelial erosion, even though you have done a perfect surgery. Because of this, the patients will have a lot of discomfort, redness, watering, and also decreased vision on the day of surgery. But when we look at the patient workflow or a toric patient with EQ workplace and a Markerless system, there is absolutely no added step when you compare from a monofocal patient. You'd just be the same, and on the day of surgery, patient's so much more comfortable. He's so happy. His vision also is much better. So I'd like to conclude by saying we need to be efficient, not just at work, even in everything we do, even the smallest thing like brushing, or even when you're wearing your clothes. Keep thinking on the most efficient way of doing. That way, you're rest assured, no matter what you do, you're doing your best. Thank you for your time.
Thank you, Naren, again for a very nice presentation. There is a question for Dr. Sri Ganesh, and that is the case in which the nanophthalmos case. There's a question on YouTube channel that do you think a lot of manipulation was done in that case, and will the angle get damaged?
No, the patient, non-ophthalmos patient already had multiple angle closure attacks and then had also PI done, had extensive posterior synechiae. We released the posterior synechiae, put in the malignant ring. There was not much of manipulation at the angle. And you put in a heavy viscoelastic like viscoat at the angle, deepen the chamber. Sometimes it stretches the trabecular meshwork also, improves the outflow. And of course, I still have to see this. I just saw the first day post-op, corneas were clear. There was not much of reaction. And I put the patient on steroids, oral steroids, which has to be done in non-ophthalmos because it reduces the incidence of choroidal effusion. So I put the patient on 40 milligrams oral steroids for a week, and then we'll taper it off. And these are the precautions: pre-op atropine, mannitol, and then oral steroids. But the patient was doing very well. Like I said, patient had 618 uncorrected vision, and we'll have to see corneas were clear. And, we called her after a week to again check IOPs, but should be okay. She was already on anti-glaucoma medication, 2 drops. So we'll have to see whether it reduces.
Thank you, Shri Ganesh. There is one question which Dr. Ishtaq, I think one issue which he raised, and he said that there's a problem for the right eye and left eye, and I would request Dr. Chityal sir to say that, you know, what he does since he has such a high volume of cases, right eye and left eye, and if you have only one machine, or do you actually require 2 machines? So you place one for the right eye and one for the left?
I think in future we'll require 2 systems. But what I do, I start with one set of eyes. So first finish the left eye, then shift to right eye. In that way, you can manage the timing better. But he's right. In the beginning, I also had a little bit of adjustment right and left eye. With the screen is slightly different for left and right eye. But as you keep operating, the things become very, very simple. Doesn't hamper your thinking also.
I think
So
it has a thick wire.
spinal level.
Maybe wireless system. If it comes, it may be more useful.
Yes, sir.
That I think Sri Ganesh can tell us.
Yeah,
Okay.
I do not see. I do not have any problem because what I do is I have tables which get pushed in. So I am sitting. My position is fixed. I don't change my foot pedals. I don't change anything. The table comes in for the right eyes. It comes in from the right. For the left eyes, it comes in from the left. So there is no issue at all. And then the cable is taken in the periphery of the room, and then I have the television there. So the cable does not obstruct the television. You cannot have wireless because the wireless transmission is not good enough to relay the 3D and HD relay. So you need to have wires, and then it is again limited to, I think, about 15 feet. You can't have very long wires also because that will again give rise to lag. So these are all issues that we went through while developing it. But regarding the tilt, of course, that will be taken care of. The different system, basically, which does not have ocular, so you can look over the microscope.
So, Dr.
I agree.
Yes, sir. Yes.
I agree with Sri Ganesh. I'm using the same system where the patient is wheeled in, and after every surgery, it is not the patient changing; it's the trolley coming in, and the position is I picked it up from Sri Ganesh. Only position of the microscope and the machine and the ARTEVO remain the same. The trolleys are placed at an angle for right eye like this and left eye like this. So there's no issue, and we don't differentiate between right and left eye as the list is coming. So there's no issue in that.
Narayan, you wanted to say something?
Yeah, yes, ma'am. So actually, I was about to tell the same that see, if you have a small OT or big OT, actually, if you do plan it properly, it is possible to move the tables or the beds in such a way that you don't need to move too much. Maximum you can, even if it is in a small OT, you just have to tilt the screen. That's all. That's the max you need to do in a small OT for a right and left eye. I would say the immediate solution, I think for now, like everyone is saying, wireless system and all, I think the simplest solution, if at all you really can't operate and it's moving a lot, you want to think of a solution, I think to have one more screen, not a full RTO, just have one more screen on the other side. And that way you can, just simply keep looking there and operating. You don't need to shift any wires.
But splitting the lights won't affect the quality of image.
It's not splitting the light, sir. It's only splitting the taking the output, sir. In the sense, from the wire, we'll have two outputs, which will be going to one screen and this. So simultaneously, both screens will be viewed. So you just need to move yourself and see which screen you need to see. I mean, that's
but the screen is very expensive. So it's a medical grade monitor, and it's pretty expensive. So that's the.
I think the MI system, MI TVs, I think we need.
But it's quite efficient, and once you get used to it, if you have these rotating tables, I do 15-16 surgeries an hour, and it's very efficient. It's not a problem.
15-16 surgeries.
So Ganesha, if I can ask you a question, sir?
Yes.
Yeah, go ahead.
Yeah. So actually, wonderful surgeries. I mean, it's really nice to see your skills every time. I was just wondering, for the first case, sir, any particular reason why you didn't take the whole complex out and then place it in? I mean, any particular reason to?
Why did you have to, de-skin it first?
Skin it and all.
And then, put.
Yeah. See, the thing is, you have to make an incision.
Incision,
and then,
large size.
a larger incision. Remove the whole bag with the lens, and then use a new lens. So instead of doing that, this is minimally invasive. Just 2 side ports, 1 mm side ports, you can manage to do the whole surgery. You just need to remove the capsular bag from the IOL, so that the IOL is left behind, and that can be done easily. And then you do a vitrectomy, and you can see the fixation is quite easy. So 15 minutes, you can finish the surgery.
The other option is if you can just strip the later part of the haptic and leave the capsule which is enveloping the margin of the optic. So you can leave that and maybe strip the half of.
No,
haptic.
but there was a sommering ring also. You could see that.
Yeah, that you had removed by vitrector, no?
Yeah. Otherwise, what happens is that kind of drops into the vitreous, or it floats into the antechamber, iritis, secondary glaucoma, all those problems. So you need to do a thorough job. You remove everything. You don't need the capsule there. You don't need the remnants there. You just want the IOL. It was a 3-piece IOL. If it's not a 3-piece IOL, then definitely you have to kind of explant it and then put in a 3-piece IOL. But this was a SI40, a 3-piece IOL. And it saves cost to the patient also.
No, what I meant was that you can remove the sommering ring, but if the capsule is just around the optic and a little bit on the haptic, then maybe capsule around the optic is not going to cause any reaction. That's what I meant. Because stripping,
but you have removed the posterior part, right? So if the anterior part slips later on, comes into the antechamber, it's going to rub against the iris. So it's actually quite easy to remove it. So I just showed the technique of how it can be done. With a Sinski, you can just strip it off.
I think we've had a very useful discussion. It was like a meeting on ARTEVO and digitization of the entire cataract surgery that is going to happen in future with all the gadgets. And we would like to thank all the speakers for sparing out their time and for being with us, for showing excellent presentations. Particularly, we would like to thank our international speaker from Bangladesh, Dr. Ishtaq Anwar, for being with us today. And also like to thank my co-moderator, Dr. Rajesh Sinha, Professor Tityal for going through the whole gamut of the thing, Dr. Shri Ganesh for showing us such excellent cases, Dr. Grewal sir. I think he is the first person to adopt any new technology that comes, and we all learn from him. And then Dr. Naren Shetty for an excellent presentation in the end to show us how everything gets integrated. Thank you, Zais, for doing this. And this is our third in the series of the digitization of the operating microscopes, which we've finished today. And we started with the posterior segment, and then today was the anterior segment, and in between we had both anterior and posterior segment. So thank you, Zais. Thank you, all the speakers. And we had, although this is such a advanced subject, and not everybody can buy this, but still we had a lot of viewers on the YouTube as well as on the Facebook. And thank you all the people who watched us. And thank you the audiovisual team, Mr. Sunil, Kripal Rana and Raki at the back, who manage this day in and day out. So thank you everyone, and hope to see you on another platform next time in a webinar.
Thank you. Thank you, everyone.
Good night.
Thank you. Bye.
Good night.
Good night.